Cervical exams are not done with each prenatal visit, but they usually are done sometime during the pregnancy, especially if they're close to delivery. So cervical exam is going to give us some information about, are they going into labor, those type things. But we'll mention that a lot more when we talk about your intrapartum lecture a little bit later. So those are some general things that you would do in addition to just your normal head to toe stuff that we do for everybody. Some danger signs of pregnancy. So one of the big things during the antepartum period is there's a lot of things their body's going through. Some of those are expected findings and some of those are very worrisome findings. So with your danger signs of pregnancy, these are things that they would need to report to their physician. So spotting or bleeding. And we tell patients to report it even if it is spotting. It's not uncommon early in pregnancy to have some spotting, but we would rather them report that and let us evaluate whether or not that's a problem. But bleeding is definitely not normal during a pregnancy. It can be an indication for bleeding disorders, a wide variety of things, a miscarriage. So any bleeding or spotting needs to be reported to the physician. If they do have painful urination, that also needs to be reported because it's a sign and symptom of UTI. Severe nausea and vomiting. So nausea is very common during pregnancy, but severe nausea and vomiting is a problem. So just like if you got sick and you threw your toenails up for 6 days straight, your electrolytes would be all out of whack, you would be dehydrated. So with a pregnant patient, that can have very, very detrimental effects on the fetus and on them. So severe nausea and vomiting, where they're not able to keep anything down, they're losing weight, that actually is going to classify that as a condition known as hyperemesis gravatum, which is a severe nausea and vomiting during pregnancy that often requires hospitalization and IV fluids, electrolyte replacement, nausea medications. So severe nausea and vomiting, not normal. Morning sickness, that's okay. And morning sickness usually does get better after the first trimester. So, all right, fever greater than 100 degrees. So if they start to have a fever, we would tell anybody else to report that. So obviously our pregnant patients do as well. Abdominal pain, cramping, or I'm also going to add intermittent back pain. So contractions are not a good thing to have unless you're close to term. So if they start to have intermittent abdominal pain or intermittent back pain, that needs to be reported to the physician because it could indicate that they are having preterm labor. Dizziness also needs to be reported. It's not uncommon for a patient to be laying down. If they sit up really quickly and try to get up, they could have some dizziness. But any persistent dizziness that's not related to position change needs to be reported to the physician. Any calf pain, and I'm also going to add shortness of breath to that one. So during pregnancy, because the body knows that when this pregnancy ends and you have a baby, that there's going to be some blood loss there. So during pregnancy, there's an increase in the clotting factors that are in the body, which predisposes pregnant patients to blood clots. So calf pain could be indicative of a DVT, whereas chest pain could indicate a pulmonary embolism. So both of those would need to be reported to the physician. Any leaking of fluid, so if their amniotic sac were to rupture and they were leaking fluid, that would definitely need to be reported to the physician. Any decreased or absent fetal movement, we mentioned this earlier, so typically they should feel their baby move pretty much every hour. A lot of times if they're up and moving around, they may just not notice it as much. But if there is truly a decrease in fetal movement or absent fetal movement, that needs to be reported to the physician. Sudden weight gain or edema, that kind of goes, all three of those last ones kind of go along with your complications of pregnancy, something known as preeclampsia. So some edema, pretty common during pregnancy, but if it's a sudden weight gain or they're having a lot of edema, they're having vision changes or right-sided upper abdominal pain, that needs to be reported because it can be an indication that they are experiencing preeclampsia. Okay. All right, so the next thing that we're going to talk about is going to be your test and your labs. So this is going to be kind of in depth, but there was a table in your pre-class assignment that went over this. So we're going to go over each one of these as well. So a CBC is going to be a complete blood count. And your CBC is going to include your platelet, your H&H, and your white blood cell count. So your white blood cell count is going to help determine if there's any active infection. Your normal range is 5 to 10. Your H&H is going to tell us if there's any anemia. And then the platelet count is going to be related to clotting. So an increased platelet count is going to be higher risk for having a blood clot, whereas a low platelet count gives a higher risk for bleeding. And it is pretty common, or at least there are some patients during pregnancy that do have a slightly low platelet count. So it's really important to know what the baseline is so that we know if that's abnormal for the patient. That's typically going to be drawn at least first and third trimester, but could be drawn any time during pregnancy. For blood typing, this is exactly what it sounds like it is. It's going to give us a typing on their blood. So are they A, B, AB, or O blood type? And in addition to that, it's also going to give us if they're positive or negative. So the biggest thing for this is they'll usually do it during the first part of the pregnancy. And then we will also do it when the patient comes in to the hospital for labor. So if the patient is a negative blood type, so O negative, A negative, AB negative, any of those negative blood types, they're going to need to get RhoGAM at 28 weeks. RhoGAM is a blood product, and RhoGAM is actually going to help protect any subsequent pregnancies that they have. Sometimes there can be a cross between the blood, and it can actually cause a later pregnancy to be seen as a foreign body, and it can attack the pregnancy. So the RhoGAM is not for this pregnancy, it's for any other pregnancies that they should have following this one. So the way this works is if the mom is a negative blood type, she will get a RhoGAM injection at 28 weeks because we don't know what the baby's blood type is at that point. And then pending the results, so after delivery, within 72 hours, if the baby is a positive blood type, the mom will then get an additional dose of RhoGAM. So I'm just going to repeat that so it's not confusing. So if you have a mom that is A negative, B negative, AB negative, or O negative at 28 weeks during her pregnancy, she should get a RhoGAM injection. After delivery, we will do blood typing on the baby, and if the baby is a positive blood type, then mom will get an additional RhoGAM within 72 hours after delivery. If baby is a negative blood type, she will not need that postpartum RhoGAM dose. RhoGAM is a blood product, so if you have a patient that's a Jehovah's Witness, we need to be very mindful to make sure they understand that that is a blood product. Rubella. Rubella is going to be something that we are finding in our childbearing age patients that they need a titer shot. So an MMR contains a rubella. So it is a childhood vaccination that they should have already gotten. But some of our patients need a booster shot. But it is a live virus, so it cannot be given during the pregnancy. So we will test them early in the pregnancy to see if they need it. And if they do need it, it will be given post-delivery, because it can affect the fetus. So we usually give it in the postpartum period in the hospital with instructions not to become pregnant for at least a month. Part of our discharge planning for our postpartum patients is to avoid sex for 4 to 6 weeks, so they shouldn't become pregnant, but we do need to make sure we tell them that. So for your rubella titer, I'm not going to ask that you know the levels. I will tell you, how to interpret that, like I'll give you the interpretation. So for a patient that has a rubella titer that shows immunity, or if it is immune, they do not need a rubella vaccination. If the lab comes back and it is non-immune or equivocal, they will need a rubella vaccination post-delivery. We will also assess hepatitis B status. Most patients now have had hepatitis B as part of their normal vaccinations. We will also check HIV status because that would indicate the plan of care would need to be changed if they come back and they are HIV positive. The patient would then be placed on different medications, and there's a protocol that we use when the baby's born. So we check HIV status as well. We will also perform a lab test called a VDRL or an RPR. It doesn't matter which one they do, it tests for the same thing. So both of those are going to be testing for the presence of syphilis, which is a bacterial STI that can be treated, but syphilis can wreak havoc on a growing fetus. So it's very important that if they do have a positive VDRL or an RPR, that we are very aggressive in treating that patient, and that is usually done in first and third trimester, because obviously you could potentially contract that during the pregnancy itself. We will also do a cervical smear and a pap smear. So a pap smear is going to test for HPV strains that can cause genital warts or cervical cancer. But during that process, we'll also do a cervical smear or culture to look for gonorrhea, chlamydia, trichomonas, bacterial vaginosis, a lot of the STIs that can cause problems during the pregnancy. You'll also see a alpha-fetoprotein offered to the patient. It is not required, but it is something that all patients are offered. You may even see it called a triple screen or a quad screen. It all means the same thing. So basically it's a blood draw on the mom, and it actually tests for the likelihood. It's not diagnostic, but it gives us if there's an increased risk for certain diseases like spina bifida, hydrocephalus, chromosomal abnormalities like trisomy 18 or trisomy 21, which is your Down syndrome. So if your alpha-fetoprotein or quad screen comes back positive, it means that you have met the parameters for potentially having one of those disease, the baby has met the parameters for potentially having one of those disease processes, and it would require further follow-up to make sure so we can get an accurate diagnosis on that. Ultrasound. So ultrasound can be used all during pregnancy just to determine the well-being of the fetus. During first trimester, we're usually looking at it to confirm the pregnancy and to give us a working due date, and it requires a full bladder. In second trimester, if they're doing ultrasound, they're probably looking for a in-depth anatomy screen to make sure everything looks well with the baby, and that's also the time that they usually will tell you gender of the baby also. If you're doing an ultrasound during third trimester, then you're probably looking at presentation and growth of the fetus. Group beta strep is going to be a bacteria that a lot of women carry in their vaginal area. It's considered natural flora for some women, and it doesn't cause any problems for them, but for a growing fetus, if that baby were to deliver and pass through the vaginal canal and come in contact with a group B strep, they can actually become infected and become septic. So the nursing application for that is we assess group B strep status during first and third trimester, and if they're positive, they're probably going to require antibiotic treatment in labor to prevent infection of the fetus or the baby once it's born. HSV is going to be herpes. So there's two types of herpes. Type 1 is what we consider the virus that causes the cold sore on the mouth. Type 2 is genital herpes. However, this day, if you have oral sex, you can actually have type 1 in different locations. But if they have herpes and they have an active infection during or at the time of delivery, they're going to be required to have a C-section, because the baby can pass through that vaginal canal, and if there's herpetic lesions there, they can actually become infected with herpes as well. So if they have an active outbreak of herpes, or they're having prodromal symptoms that they're fixing to have an outbreak, then the physician will likely require them or encourage them to have a C-section to prevent any cross to the baby. Cytomegalovirus and toxoplasmosis. So cytomegalovirus, we kind of went over some of the things, washing your fruits and vegetables, those type things. Your toxoplasmosis is going to be something, it's the reason that when you go in for your prenatal visits, they ask you if you have a cat. So toxoplasmosis is something that's found primarily in cat feces. And so what we teach our patients about that is if they have an indoor cat, somebody else needs to be the one to change the litter box. So that'll take care of that one. We'll also do a glucose screening to determine if they are gestational diabetic. So that's usually done between 24 and 28 weeks. And they will come in and they will make you drink this. It tastes kind of like orange knee-high. It's just really, really sugary. And then you'll drink it. An hour later, they'll check your glucose level. And if it is high, then they will do some further testing. So most resources will say that that 1 hour glucose screen should be less than 135. If it's greater than that, then that usually requires them to do some further testing called a 3-hour glucose screen, and then that will determine if they're gestational diabetic or not. Gestational diabetes is not something that we're going to cover in depth this semester, but it does increase their risk during the labor process. There's some issues with the baby that can occur, and it does increase their risk later on of developing diabetes. However, true gestational diabetes will go away after pregnancy. It doesn't mean they won't have issues later on. Some other tests that are not necessarily routine tests, so I'm just going to kind of mention these a little bit. So your non-stress tests, I'm going to explicitly go over with your intrapartum stuff when we look at fetal heart rate strips. But basically a non-stress test is where a mom comes in and we assess the fetal heart rate of the baby and we see if there's any signs, see if the baby looks healthy on the fetal heart rate monitor or if there's issues. So we'll talk specifically about the guidelines for that. That's not routinely done, but if you have a mom that's high risk or she's gestational diabetic or she has preeclampsia, if she's having issues during the pregnancy, it's a non-invasive way for us to check and see how the baby's doing inside. Now, if that non-stress test did not come back like we wanted it to, then we can't even do a higher level test called a biophysical profile. And a biophysical profile is basically just an ultrasound evaluation of the baby to see how it looks. So it has certain criteria, and the best score that you can get is an 8 out of 8. It means everything looks good. If it's less than that, then that's going to be something that we need to make sure, look at specifically as far as guidelines of, do we need to deliver or is this just a sleepy baby kind of thing. So I'm not going to ask you specific questions about that. 8 out of 8 is what you want. If it's less than that, that needs to be evaluated by the physician. Nuchal translucency screen, I'm just going to mention. So if they had a positive alpha-fetoprotein, they can actually do an ultrasound evaluation, and nuchal means neck. And there's some of those disorders that show abnormalities in the translucency of the neck. And so that's just going to be an ultrasound test to further confirm or deny the presence of congenital anomalies. The end-all be-all, if they're looking for confirmation if that baby has Down syndrome or some of the other issues, would be an amniocentesis. And an amniocentesis is an invasive procedure. So the non-stress test, the BPP, the nuchal translucency, all of those are non-invasive. The amniocentesis is very invasive. So with an amnio, what they do is they take an ultrasound monitor and they actually find a pocket of amniotic fluid. They insert a needle through the mom's abdomen into the amniotic sac, and they withdraw some fluid, and they send that fluid for testing. But an amniocentesis would be diagnostic, so they could confirm if there is presence of trisomy 18 or Down syndrome, those type things. So it would be a diagnostic test for that. It does, however, carry some risk because you have essentially punched a hole through the amniotic sac, and if that doesn't seal off, then you can have some labor, like preterm labor issues. There's 2 reasons that you would do an amniocentesis. So during the first, like once they're doing the AFP, so late first, early second trimester, if we're doing an amniocentesis, we're probably looking for diagnosis of some of those chromosomal abnormalities. If they're doing it more third trimester, like 34, 36 weeks, they're probably assessing lung maturity. So if you're seeing it one versus the other, it'll kind of tell you why we're doing it. So if we have a mom that needs to deliver, but she's early, let's say she's got some health problems, we can actually do an amnio, draw some fluid, and we can send it for a specialized test and determine if that baby's lungs are mature, so we'll kind of know what the game plan would be or how well that baby would do outside of mom. So obviously an amnio, because it is so invasive, is not a routine test by any means. education during pregnancy. So exercise, general guidelines for exercise are going to be that if mom's an avid runner, then there's not any reason she can't continue her normal exercise routine with some modifications. So obviously if she's a runner early during the pregnancy, she's probably going to be able to do that without any problems. Later on in pregnancy, it may be very uncomfortable, so she needs to make sure that she supports her abdomen, and there may be a point in time where her walking has to become more of her running may have to become more of a walk because of comfort level for the pregnancy. If mom does yoga, that's completely fine for her to continue that as long as she makes some position modifications to ensure the safety of her and the baby. So she could not lay completely flat on her back, and she would not need to lay completely prone on her stomach. But if she could work around those two positions, she could continue that. So basically, you don't want to start a new exercise and go, all in with active running if you've never done that before. But if there's exercise levels that they've already established, they can maintain those. They need to be mindful not to be putting themselves at risk for falling, hitting their abdomen, avoid temperature extremes. But there's not tons and tons of restrictions on exercise. The more active they are, the better. They just need to be safe while doing it. As far as travel, travel is pretty safe during pregnancy as long as they do understand their increased risk of blood clots. So if they're traveling by vehicle, they need to be getting up, getting out of the car, ambulating every so often to help prevent that. And then we do discourage travel during the end of second, first, and then during third trimester because you're going to be higher likelihood of complications and or labor at that time. So if they must travel during those times, we usually provide them with a copy of their prenatal record so that they will have that should something happen and they need to go to the hospital. Vaccinations are fine during pregnancy as long as they're not live vaccines, so that's the reason the MMR has to be held until after delivery because it's a live vaccine. So the flu vaccine is actually highly recommended for pregnancy as long as it's not the flu mist because that is a live vaccine. You're also going to discuss with your patient birth plans and birthing locations. So a birth plan is basically just a typed out or written out this is kind of what I want during my pregnancy. They can be very generic or they can be very specific. They can be very restrictive in some ways, and some of them are just things that we normally do. So if they do have a birth plan, that needs to be something that's discussed with the physician and them, and then of course with the hospital staff when they come in. So for example, if a patient comes in and their birth plan states, I don't want to have an IV, I want to eat during labor, I don't want my water broken, I don't want to be on the fetal monitor, but they show up and they're there for induction of labor and we have to do all those things to be able to induce them, then that would be contradictory to their birth plan and we would need to have a conversation. Some birth plans are just, I want my baby with me as much as possible, I want to do skin-to-skin post-delivery, and those are things that we already do anyway. So we do try our best to accommodate what they want for their birth, but we also have to make sure we're maintaining safety for them and for the fetus. Birthing locations, by far most patients are going to have babies in hospitals, but there's also freestanding birthing centers that may offer whirlpool delivery or water births and different things. And then of course there are some patients that may even opt for home deliveries. In the state of Alabama and Georgia, that is not legal per se. It can't be attended by a healthcare professional. So by far most patients are going to opt to deliver in a hospital because there's definitely some safety features built into that we have all the equipment and staff we need to be able to take care of any emergency that should arise. We'll go ahead and ask them about breast or bottle feeding because it may change what we do as far as medications during the next phase when they come in for delivery. And then we also encourage childbirth education for our patients, and there's a lot of different types of childbirth education, and we don't necessarily like one over the other. It's kind of what works best for the patient, but two that are commonly used is going to be Lamaze, and that's going to be the one that has the breathing, the that you see on TV. So it does kind of rely on breathing exercises and relaxation techniques to help get the patient through labor. The Bradley method is also one that we see used a lot, and it's more partner coached. It does use exercises and controlled breathing, but it's not quite as restrictive as the Lamaze as far as the breathing techniques that it uses. So there's a lot of different types out there. As far as medication safety, medications for pregnancy are listed A through X. So I'm going to start at the top and go down. A is going to be safe during pregnancy. Your vitamins are going to fall into this. B is probably where the majority of medications are going to fall. So relatively safe. There's no known tetragenic effects, so it's not going to be damaging to the fetus that we know of. Tylenol, most of your antibiotics are going to be category Bs for pregnancy. Category Cs are going to be those that can cause some issues, but the benefit may outweigh the risk. So antidepressants, a lot of your antidepressants are going to be category Cs for pregnancy. A lot of your seizure medication may be as well. Category Ds are going to be the fact that we know there's some health risk to the fetus, such as alcohol. Some of your seizure medications will fall on this one as well. And then your category X, we have absolutely found that these can cause birth defects and they are contraindicated. So Coumadin is not used during pregnancy because it can cause birth issues or birth injuries or fetal injury. So your category X are going to be those drugs that are contraindicated. So for testing purposes, you could, if I told you that a patient calls the clinic and the medication that they're wanting to take is a category D, then you would need to know how you would provide education based on that specific guidelines. So if we know it has health risks, like alcohol, then we would tell them to avoid that. If it's a category A, then it's safe to take. So that's how that can be translated into test questions or scenarios. All right, common medications during the antepartum period. There's really not a lot. These are pretty easy, but we're going to hit them. Prenatal vitamins are usually prescribed for all pregnant patients, and they come in a variety of sizes, and they can be gummies, so there's really not any reason. The biggest complaint we had about prenatals is they used to be like horse pills. They used to be really big, but there's so many different options out there now for your pregnant patients that they should be able to find a prenatal vitamin that works for them. It is important they take it because it does have iron and all the nutrients in it that they need, so it helps to support a healthy pregnancy. Biggest complaint that we see is nausea with prenatal vitamins, and if they are experiencing nausea with those, then what they can do is take those at night, and they tend to sleep through the nausea, so that is something that you could recommend if they're having a little bit of nausea. The prenatal vitamins also may change the color of their urine and make it kind of a psychedelic fluorescent color. That's completely okay. It's just a vitamin. No need to worry. The other one that you may see prescribed is going to be your iron. So I'm just going to hit the high points on it. In Hospital Utopia, it would be perfect if we could take that on an empty stomach with a big glass of orange juice because vitamin C helps to aid the absorption of the iron. However, it can be taken with food if there's GI upset. It is going to tend to cause constipation, so they're going to need to increase their fluid and fiber in their diet. It also discolors their stool and makes it dark, so they need to be educated on that as well. So ideally take on an empty stomach with vitamin C, but can take it with food to decrease GI upset, increase fiber, increase fluid, and educate them that their stool may change and become very dark. And if we know in the healthcare profession that dark stool can indicate blood, but with iron it's just because of the medication. It doesn't indicate that they're bleeding from there. Okay, that is it for antepartum. So I am going to come back with your next video. So this is it for antepartum.